Good afternoon, ladies and gentlemen. Thank you for having me present our journal club today. We're going to take a look at the idea of blocking the renin-angiotensin-aldosterone system in two different areas. We'll focus on the Altitude trial, which is a recent trial about blocking this particular hormonal axis in two areas, but we are going to go over some other trials briefly so that we get a clear understanding of this particular concept. Dual renin-angiotensin blockade, which I've noted here as RAS, is an intriguing concept because there are many studies that show significant therapeutic benefit when you block one element of this hormonal axis. It's especially true in diabetic patients, for which many of us have and see in the office. And it's true for these patients when it comes to cardiac endpoints and even some renal endpoints. So it actually makes a lot of sense to wonder whether you can get an even greater therapeutic benefit if you block this hormonal system in two areas or more. This is a brief schematic of how the renin-angiotensin-aldosterone system works and the different target organs that are affected by different components of this axis. And what we're trying to look at is whether blocking the axis in two different points would extend a therapeutic benefit to more than just one target end organ system. Now, I want to review rather briefly some of the trials that have shown that monotherapy with ACE inhibition exerts a therapeutic benefit. Most of these trials look at cardiovascular and all-cause mortality as their primary endpoint, but almost all of them show really positive results when you use ACE inhibition as a monotherapeutic agent. You can increase your functional status, decrease your mortality, alter LV modeling and progression of heart failure, and in some cases, if you are pre-diabetic, you can actually retard the progression of overt diabetes mellitus if you use an ACE inhibitor. So monotherapy with ACE inhibition, as all of us know by now, is really of great benefit. It really affects some of the hard outcomes that we all want to see in drugs that we use, and that's why many of us use ACE inhibitors. But ARBs are just as good at exerting a therapeutic benefit for a number of these primary outcomes. In the LIFE trial, there's a decreased risk of MI and stroke. In the IDNT and renal trials, which are trials that are very specific for nephrologists, there's a reduction in the progression of diabetic nephropathy. The CHARM trial shows a reduced admission rate for CHF patients. So a lot of these trials using ARBs are just as positive as the trials that use ACE inhibitors, in that they show tremendous therapeutic benefit if you use this particular agent as a monotherapeutic agent. So what about dual blockade? Dual blockade makes a lot of sense theoretically because if an ACE inhibitor exerts a wonderful therapeutic benefit and an ARB does the same thing, then blocking the renin-angiotensin-aldosterone hormonal axis using both of these agents ought to give us some similar, if not synergistic, therapeutic benefit. Now, you may not be able to read this slide, but there are 37 trials that look at dual blockade and assess whether it's safe, effective, or both. We're going to focus on the most recently published study, which is the Altitude trial, and then very briefly discuss an ongoing study, which is extremely important for anyone taking care of kidney patients. That would be the VA Nephron D trial. The Altitude trial in the New England Journal of Medicine at the end of 2012 was a double-blind randomized controlled trial, and the the participants are as follows. In the first arm, you have aliskiren, which is a direct renin inhibitor, combined with either an ACE inhibitor or an ARB. So that's the dual therapy arm. And in the second group, you have placebo with either an ACE inhibitor or an ARB, and so that's our monotherapeutic arm. 853 centers participated across 36 countries, over 8,500 patients, generally 35 years or older, and they had type 2 diabetes, and they had evidence of at least microalbuminuria or macroalbuminuria. To win this fight in this particular trial, you had to have a decrease in the time to cardiovascular death, your occurrence of a cardiac arrest, non-fatal MI, stroke, ESRD or doubling of creatinine. Now, the last two are important for anyone taking care of kidney patients because these are primary outcomes in the altitude study: the development of ESRD and the doubling of creatinine. Unlike many of the other studies that we briefly discussed and that you may be familiar with, renal outcomes are generally secondary endpoints. Here's a study where within the primary endpoint are two important renal outcomes. Here are the baseline characteristics of the patients in this study. They're pretty well matched if you go down this table. The average A1C is about 7.8%, give or take 1.6. There's a good distribution of individuals who have different stages of CKD, a good distribution of individuals with varying levels of albuminuria. The study started in 2007 and was designed to follow for 3 years. They needed 8,600 patients to achieve the statistical significance that they set for themselves. And the aliskiren arm, patients started at 150 milligrams and were titrated up to 300 milligrams if they could tolerate it. So the results, well, this is table 2, which I call the money table because it pretty much tells you everything you need to know about this trial. And unfortunately, you'll look at the right-hand column, which is the p-value, and there are very, very few p-values less than 0.05. In fact, the only one that's less than 0.05 is cardiac arrest with resuscitation, where there was less cardiac arrest with resuscitation in the placebo arm than in the arm that has the dual therapy. And so what you see here is no statistical improvement with the dual therapy, aliskiren plus an ACE or aliskiren plus an ARB, when it comes to these hard primary outcomes. There is an improvement in albuminuria when you have dual therapy. And this actually brings up a very good point because for years we've been using albuminuria or proteinuria as our surrogate marker for hard renal outcomes, time to ESRD or doubling of creatinine. And it seems, at least in the altitude trial, that we may have to revisit whether albuminuria is an accurate surrogate. We've certainly used albuminuria with monotherapeutic agents such as ACE inhibitor trials and the ARB trials, and then we've come to learn that albuminuria has been a good surrogate marker for these hard renal outcomes in those monotherapeutic trials. So it certainly made sense to use albuminuria in a dual therapy trial, but when you look at the actual primary outcome, which you thought albuminuria would represent, it turns out that there's an uncoupling between what albuminuria represents and your primary outcome, your hard primary outcome. There certainly was some risk of hyperkalemia and hypotension in the group of patients that received dual therapy. I think a lot of us would manage hyperkalemia and hypotension as best as we could symptomatically, but it's a little bit hard to convince a physician to do so if the primary endpoint of mortality and ESRD development isn't altered when you use dual therapy. So now on to the VA Nephron D trial. It's a trial that hasn't been completed yet. It started enrolling, I think, in 2009. It'll be completed in 2014. And it also looks at dual renin-angiotensin blockade in proteinuric diabetic patients, very similar to the altitude trial, except in the VA Nephron D trial, you're looking at lisinopril and losartan versus losartan alone. There's been some controversy whether a direct renin inhibitor like aliskiren actually exerts therapeutic benefit all by itself in a monotherapeutic environment. And so it appears that in the VA Nephron D trial, the investigators are looking at two agents, losartan and lisinopril, that alone have been shown to decrease albuminuria, proteinuria, and your development of diabetic nephropathy. So it makes a little bit more sense to look at two agents that we know on their own can give us the positive therapeutic benefit rather than looking at one agent that might be a suspect. That would be aliskiren. Um, Thankfully, in this trial, which is all run by nephrologists, the outcomes are all renal specific. All primary outcomes are renal specific. This is exactly what we want to look at. We don't want our renal endpoints to be secondary. So we're going to use lisinopril and losartan versus losartan alone to determine if there's any impact on primary renal outcomes. That's somewhat different than the On-Target trial, which also looked at ACEs and ARBs in a dual therapy fashion and a monotherapy fashion, but used these renal outcomes as a secondary endpoint, not as a primary endpoint. Now, the trial is not done, and at the latest NKF spring clinical meetings, I do not believe that there was any formal discussion of the results. But based on the Twitter feed from NKF spring clinical meetings, there's been talk that the results are not positive. I wish I could get into more specifics, but nobody at the meeting could get into any specifics. And certainly on Twitter, I wasn't able to find anything more specific than this general negative sentiment. So I caution everyone to hold off on their final judgment with this trial. Certainly keep your eye out for it, because it will definitely be something we want to look at. It's focused on patients that we take care of and looking at outcomes that we really care about. And I do hope that the general sentiment on social media and on Twitter is not really what pans out when the trial is all complete. If you look at a meta-analysis of dual blocking trials shown here in the British Medical Journal of 2013, you'll see a variety of trials. Altitude, on target are included in this. This particular hazard ratio diagram refers to all-cause mortality. And at the very bottom of the screen, you'll see that the risk ratio is touching 1. And so there is really no favor of dual renin-angiotensin-aldosterone blockade if you're trying to decrease all-cause mortality. It's certainly not any worse, but it's not giving you the kind of benefit that we would have expected based on all of the monotherapeutic trials using ACEs and ARBs. This particular diagram includes ACEs, ARBs, and direct renin inhibitors in some combination. But when you put it all together, there is no benefit in using double blocking therapy. So in summary, here we go again, where we have a clinical trial that seems to be well done, the Altitude trial, and does include renal endpoints as the primary outcome, which is what we want and not always what we get. But yet we see not a negative result, but an unequivocal result of no effect. I've listed some trials here, some recent trials in 2012 and late 2011 that brought our hopes up, but then subsequently indicated that there is really no effect. The BEAM trial, that was bardoxolone. A lot of talk about bardoxolone slowing the progression of diabetic nephropathy. That doesn't seem to be the case. The EVOLVE trial, a lot of hopes that cinacalcet would alter cardiovascular disease endpoints by affecting calcium phosphate deposition. That doesn't seem to have a positive effect. The TREAT study, suggesting that higher hemoglobin levels actually lead to higher risk of cardiovascular events. Now, there's been many subgroup analyses done of the TREAT data, and there's a lot of talk amongst investigators and academic nephrologists that it's really not the hemoglobin level, but the ESA dose that's causing the cardiovascular event. I haven't seen any randomized trial to tease out whether it is the hemoglobin level or the dose of the ESA, so I can't say with certainty that a higher hemoglobin level in the absence of an ESA is just as good as a lower hemoglobin level, or at least doesn't confer a negative effect. The SHARP trial, which came on the heels of the 4D trial and the Aurora trial, pretty much said that if you use a statin in advanced CKD and ESRD patients, you should not expect a decrease in cardiovascular outcomes. And then finally, the Cooperate trial. Now, the Cooperate trial is a somewhat older trial, somewhere in the mid-90s, I believe done in Japan, looking at non-diabetic patients who received dual renin-angiotensin-aldosterone blockade and actually showed a positive benefit. Now, I know that this study is looking at non-diabetic patients, and many of the studies that we covered in previous slides looked at diabetic patients, which is a totally different group of individuals who respond very differently to these medications. It was the Cooperate study was a really great study, except there was a lot of ethical dilemmas and issues that came up subsequent to its publication, and about 6-7 years after it was published in the Lancet, I believe it was retracted. Since then, I haven't really been able to find any studies that look at non-diabetic patients who receive dual renin-angiotensin-aldosterone blockade, and that's somewhat of a shame because I'm not sure if dual blocking therapy would still be of benefit to a select group of individuals, namely non-diabetic patients. This study seems to have really put a damper on anyone else evaluating non-diabetic patients with dual blocking therapy. So here we are, where we think something is intuitive, but yet we don't get the results that we wanted, And I've just illustrated that here at the bottom. So I want to thank you for joining me for this really brief evaluation of the dual renin-angiotensin-aldosterone blocking concept. Hopefully we'll have more data from the VA Nephron D trial in 2014, or at least prelim data in this calendar year 2013, which I can bring to you at a later date. Thank you very much.